Good afternoon, and thank you for the invitation to share this work on behalf of the members of the Consensus on Vaccination Working Group. So over the last years, vaccination has become an important part of the risk management strategy in MS patients treated with highly active drugs. However, questions remain as to when and whether to introduce a particular vaccine and which DMTs can have a higher effect on vaccine responses. In the EU context, ECTRIMS and EAN have joined forces to develop a reference tool to guide professionals in deciding on the best vaccination strategy for their patients. The members of the steering committee that you can see here had the kickoff meeting during the ECTRIMS 2020. And over this last year, a multidisciplinary team has been working following a formal consensus methodology to review the available evidence and agree on a total of 59 recommendations. Details of the whole development process were presented yesterday during the Free Communication 1 session. Given the fast-changing nature of the COVID-19 vaccine, it was not included in the present work, and we're working on a separate document that will be presented in the next talk and will be available in the EAN and ECTRIMS web pages soon. As the safety and effectiveness aspects have already been covered in the previous talk, I will focus on the proposed vaccination strategy for MS patients before, during, and after immunosuppression, as well as those specific situations such as pregnancy, children, elderly, and international travel. The three main general principles that need to be considered to tailor the vaccination plan is that we need to evaluate the immunization status of the patient. And we can do this by using serological tests and also having the record of previous natural infections. It is also very relevant to inform patients about the importance of immunization and the risks of not vaccination, taking into account, of course, their values and their preferences. Vaccinations should be performed at the time of the diagnosis, ideally, or in early stages of the disease to prevent future delays in initiation of therapies. With respects to the timing of vaccinations, vaccines should be administered ideally in early and stable phases of the disease before the onset of DMTs. In case the patient is having a relapse, ideally, vaccination should be delayed until clinical resolution or stabilization. In the case the patient is already treated with specific DMT, the vaccination timing has to be adjusted to ensure safety in the case of attenuated vaccines and to optimize vaccine responses in the case of inactivated vaccines. If there's a clear plan that the patient is going to start an immunosuppressive therapy, we have to reassess the vaccination status of the patient. Once we decide to vaccinate, vaccination has to be done according to local immunization standards and specific infectious risks of the drug. If we're going to introduce an inactivated vaccines, this can be done anytime, but ideally 2 to 3 weeks before the immunosuppression onset. For live attenuated vaccines, we have to vaccinate at least 4 weeks before immunosuppression onset to avoid potential vaccine-derived infections. Once we have vaccinated, it is important to complete a serological testing to check whether the patient has mounted a protective response, at least for those vaccines with accepted cutoff levels. For attenuated vaccines, this serological test should be done before starting immunosuppressive therapy. And in case of insufficient response, we can consider administering a booster dose or even doing a complete revaccination schedule for some vaccines. If the patient is already receiving an immunosuppressive drugs, we have to keep in mind a specific wording regarding live attenuated vaccines. So these vaccines are safe in those patients without disease-modifying therapy or treated with immunomodulatory treatments. They should be ideally avoided in case the patient is treated with dimethyl fumarate, teriflunomide, and natalizumab. However, in very exceptional cases, we can consider vaccinating with live attenuated vaccines in patients treated with these drugs if the risk of infection is superior to the risk of developing vaccine-related infections. And these vaccines should always be avoided in patients under S1P modulators, anti-CD20 therapy, and before immune restoration in the case of cladribine and alemtuzumab. If the patient is eventually going to stop an immunosuppressive drug, then again, inactivated vaccines can be administered anytime, but preferably after immune restoration. In the case of attenuated vaccines, these should only be administered after a safety interval that ensures immune restoration is met. This interval, of course, can vary between patients and depending on the drug. So with respect to the specific vaccines that should be recommended for patients with MS, it is important to update the routine vaccination schedule corresponding to their age for the general population. The influenza and pneumococcal vaccines would be specifically recommended in case of immunosuppression or significant disability. And HPV vaccine, both in women and in men, independent of their age, would be recommended in patients under alemtuzumab, S1P, cladribine, or anti-CD20 therapy. Herpes zoster inactivated vaccine is recommended for patients over 50 years of age. This age cutoff level can vary between countries in case of treatment with cladribine, alemtuzumab, S1P, natalizumab, or anti-CD20 therapy. And hepatitis B is specially recommended in non-immune patients that are going to start treatment with anti-CD20. Focusing on specific subpopulation, in the case of children with MS, the same recommended vaccination timings and precautions would apply, taking into account the authorized age for administration of each of the vaccines. For pregnant women, the inactivated influenza vaccine is specifically recommended and should be administered at the beginning of the influenza season during any trimester of pregnancy. The diphtheria, tetanus, and pertussis vaccine is recommended during the third trimester to allow the greatest maternal-fetal transference of anti-pertussis antibodies. And live attenuated vaccines are to be avoided during pregnancy and should be completed at least 1 month before or after delivery and 4 to 6 weeks before initiation of any immunosuppressive therapy. For the elderly population, the same times and precautions apply, but it is important to inform about the risk of severe infections and the altered immune responses to vaccines in this subpopulation. Influenza vaccine annually and pneumococcal vaccines are specially recommended, and they would also benefit from the inactivated herpes zoster vaccine. For patients planning to undertake international travel, mostly those going to tropical or subtropical areas, they should be advised to consult a specialized travel clinic. Ideally, immunization should be started 2 to 3 months ahead, as some vaccines have multiple dose schedules. All the inactivated vaccines that could be recommended for traveling, such as rabies, Japanese encephalitis, polio, etc., can be given to patients with or without immunosuppressive therapies. Yellow fever vaccine and oral typhoid are contraindicated in case of immunosuppression, and specifically for yellow fever vaccine that we do not have any other alternative, care providers should discuss in detail risks and benefits of stopping treatment for receiving this vaccine for traveling. So in order to conclude, as a result of the joint effort between ECTRIMS and EAN, the first European consensus on vaccination in MS patients has been developed. The document proposes a standard for vaccination in MS patients in terms of global vaccination strategy for the general MS population and selected subpopulations. These recommendations can contribute to homogenize the immunization approach for MS patients. Work is ongoing and is expected to be published soon. Thank you very much for your attention.